I know we are running behind the time, so I will not take a lot of time, but basically the whole purpose of this webinar was to come up with some consensus and way forward. Already, I think we heard and from Professor Sita and everyone else, what needs to be done. But can we just do everything based on one single trial? And the questions which were going on in the neonatologists or the academicians in India, they were like, whether we need to relook at the data, whether we need to pull this data again. And a great effort was put by the NNF working group, led by Siddharth Ramji, Deepak Chawla, Praveen Kumar sir, and our Dr. Suman also was part of this group. And they did a quite extensive and good work to pull off the data in a very short period of time, and looked at all the trials again and individually looked at the data, particularly raising the questions again about the the mortality and the neurodevelopmental outcome. And there were about so you can see there are about 24 RCTs were found, and there were 7 in the high income countries and 17 in the LMICs. And I'll just quickly go through some of the slides to show the full data of all these trials through the Forest Blast, and then we come up with some consensus on it. So as you can see, in the high income countries, the pool analysis still show that there is a reduction in the death before discharge. This is what we are trying to look at, death before discharge. The heterogeneity was low, and the pooled outcome was 0.77, so reduction in the death. Similarly, if you look at the LMIC, there are a number of trials which looked at it, and even if we added Helix trial from the data from the Helix trial, the results are showing there is a reduction in the mortality, and you can see the heterogeneity is low in this. So overall mortality reduction is 0.76 with a good confidence interval. Looking at the death before discharge studies, now where the pH has been reported, now it's very important, again the issue has been highlighted, what was the condition at birth determines the outcome. So we need to know about the pH status at birth and also the temperatures at admission. So if you look at those babies who are very sick with pH less than 7, in those also if you look at HIC, there's a reduction in the mortality, and even if you look at the pool data at the LMIC, there is overall reduction in the mortality. Now, if you look at the pH more than 7, so these are the babies which are born in a better state, the benefits are in fact better. There is a significant reduction in the mortality. Again, the heterogeneity is low here. So again, babies born in good conditions do well. Now, if you mixed all these babies and if there is no clear-cut information about their condition at birth, and if you pull all these data together, looking at all the trial, including the Helix trial, then the benefit is not much. So you can see this crossing the it's only 0.96 and it's crossing the midline, so there is no benefits has been reported. Now, other important thing is about the outborn and inborn. Again, this is a very important issue has been highlighted. So if you look at the death before discharge and where there are no outborn newborns or neonates, so all are inborns. If you look at the LMIC, the outcomes are quite favorable. It's 0.6, so there is a reduction in the mortality. But if you add outborn newborns into it, the reduction, there is not much difference, and you can see it's crossing the midline. So again, it is a very big confounder for cooling babies who are outborn, so especially when you don't know which condition they were born in and how they were transported. Now, again, another important factor, what is the outcome of death if the admission temperature is less than 36? If they are not normothermic at admission, then you can see then there is no difference in the death mortality before discharge in this baby. But if the admission temperature is normal, then you can see there is a reduction in the mortality. Again, highlighting very important about the care of the babies. Now, this is another scatter plot and linear regression line between the proportion of neonates who had severe HIE and those who died before the discharge. So blue is the intervention arm. So you can see the blue are the babies who are in the intervention arm and black were in the control arm. I mean, just to summarize this, basically more severe the severity of the HIE, more the chances of the baby will be dying before discharge. And again, as we all see this, the mortality is higher in the severe babies. So again, it depends on what kind of a population of babies you're including in the trial will influence your outcomes. Now, looking at the death or severe disability at 18 to 24 months, If you pull high income countries, again, it has been shown, obviously, there's a reduction there's improvement in the, there's improvement in the disability outcomes. But yeah, if you pull up all the data now, recent data, including the Helix trial, there is still improvement in disability, a long-term disability at 18 to 24 months of age. Again, the heterogeneity is not too high in these studies. Now, looking at the cerebral palsy at 18 to 24 months, again, HIC high income countries, it is 0.73 and it is 0.69, including the data from the Helix trial. So there is improvement in the cerebral palsy. So it was concluded that this is from the NNF paper, that their conclusions were that therapeutic hypothermia does reduce death and severability, disability and cerebral palsy at 18 to 24 months, even in LMIC compared to high income countries. Mortality before discharge for moderate to severe HI for the babies with cord pH less than 7, there was a significant in both the groups. And so again, it's favorable. But hypothermia at admission and unclear evidence of severe intrapartum asphyxia, that's a group where there's uncertain benefit from therapeutic hypothermia and it may cause more harm. And the risk of death was increases in the presence of severe encephalopathy. And that's why, again, it highlights the need of invasive ventilation, inotropic support. And that again highlights the issue that optimum NICU facilities are needed if you want to cool this baby. And the question still remains about the ethnicity, biological factor, genetic variation, difference in the intrauterine exposures. I think these all still need further studies, whether we can conclude and say with a affirmation that, this does make a difference. So their recommendation from the practice is what actually we have already been discussing. And this is the NNF statement for the practicing neonatologists in India. So the first question is, where should the therapeutic hypothermia be offered? So yes, I have no doubt that it should be a high quality neonatal care, level 3, level 4, especially the nursing ratio. If you try to care for this baby, try to have a 1:1 or 1:2 nursing, and you should have all the routine facilities for monitoring. And Professor Vishnu but highlighted that very much. And which neonates should be offered? Again, yes, these criteria are pretty standard. More than 36 weeks. Again, some centers try to do even more than 35. But this is what is proposed. And important is to start within 6 hours, and the admission temperature should be in the normal range. And the criteria followed are again pretty much same criteria which followed worldwide. And which neonates should not receive therapeutic hypothermia? That's where the important question lies. So babies who are again very sick, presenting and with congenital or genetic abnormality, severe growth restriction, severe coagulopathy, if there is a head trauma, intracranial hemorrhage, and then presenting beyond 6 hours of age, these are the baby we should probably not cool. And what future from here is, I think we still need individual patient data meta-analysis for all the trials from LMIC to address some specific issue. And there is a high urgent need of a national registry of all the neonates, because there are so many centers in India. We're cooling the data, but I think it's high time to pull this data and come up with some more concrete conclusion. Thank you.